My name's Justin Davis. I'm an interventional cardiologist from Imperial College in the United Kingdom.
My name is Ravi Bhindi. I'm an interventional cardiologist at Royal North Shore Hospital in Sydney.
My involvement in the DEFINE FLARE study was co-PI alongside Javier Escanad, leading the study in Europe and in all the countries which the study was run in throughout the world.
I led the Australian limb of this study, which comprised of 4 centres in Australia.
The data was very compelling for both studies and showed that if you use iFR or FFR to guide revascularization decision-making, you get similar outcomes in terms of hard MACE events.
Importantly, the 2 studies were harmonised for these endpoints, allowing them to be combined together to allow a larger pool of patients, which was an important part of the study. These 2 studies in combination have had quite a big impact on our practice. Firstly, it's made iFR simpler because there's a cutoff of 0.89 now, as opposed to the previous hybrid algorithm that we used. Secondly, it's allowed some of my colleagues who have been late adopters of coronary physiology to use a simpler system rather than exposing patients to the risks and side effects of adenosine and the fiddly setup in the cath lab that's time-consuming as well. So I think improving adoption of coronary physiology is pivotal, as we know that coronary angiography has problems and is not optimal in certain circumstances, and coronary physiology allows a more accurate analysis of hemodynamic significance of lesions in intermediate stenosis. The
big thing that these studies bring to the table is essentially they increase the amount of data we have by 4-fold. So the big winner here really is coronary physiology, whichever modality you use, and obviously the patients, because better clinical decisions are being made because physicians are choosing to make decisions based on physiological values rather than just eyeballing an angiogram. The outcome data has already had an effect in the United States, where iFR alongside FFR are now both in the appropriate use criteria guidelines. This means essentially that physicians can use either of these techniques to guide revascularization therapy and get reimbursement for it.